Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. We have here a patient who attended with bilateral, fully occluding earwax. We're just commencing with their left ear. And if you stay tuned, you will see when I perform the procedure in their right ear that we unearth what we call an ear canal osteoma. We'll discuss what an ear canal osteoma is in a moment or two. But before I do, you can see that I'm just performing microsuction here, and I'm trying to roll this piece of wax out of the ears. So I'm going to the top of the piece of wax and then coming downwards with the suction probe, and I'm now going to just wriggle this out of the ears. It's quite a substantial piece. It's a very soft, textured wax. This patient has got what we call the wet earwax. There's two categories of wax, dry and wet. The most common form of earwax in Western countries like the UK is wet earwax. It's probably about 95% and above. And the type of wax that you have, it all depends on a specific gene mutation. And I have talked about that previously, and I will talk about it again, no doubt, in the future. But for now, I'm just going to discuss more about the ear canal osteoma. And so an ear canal osteoma is an abnormal, benign, it's a very slow growing bony growth. It can occur in different parts of the body, but one of the places they can develop are in the ear. They are quite rare. Don't see them frequently, but they're nothing really to be concerned about, because typically they're asymptomatic. The patient's not even aware that they've got them. The exact cause as to why people develop osteomas in the ear, it's not really fully understood. Unlike for exostosis, so another condition within the ear where you can get bony growths, bony spares, is called exostosis, more commonly known as surface ear. And so it's important you make the distinction between exostosis and an ear canal osteoma. They are two different conditions. Exostosis, so surface ear, is normally bilateral. You get it in both sides, and they're categorized by typically three bony growths very deep in the ear. One superiorly, so around 12 o'clock, and another around 3 or 4 o'clock, and the final one about 9 o'clock. And exostosis, surface ear, is caused by frequent exposure to cold water or cold air, whereas an ear canal osteoma are not always caused by exposure to cold air. The patient can have no other risk factors. They just develop. Call them neoplasms. So neoplasms are abnormal growths that just occur. It could be different types of neoplasms. It could be soft tissue. It could be bony, and in this case, it's a bony growth. So with exostosis, surface ear, what happens is the exposure to cold air and sometimes, more commonly, cold water, it turns and makes the bone in the ear canal very cold. And lining that bone in the ear canal, so the osseous part, the inner 2/3, is a structure, connective tissue called periosteum. And that has blood capillaries and blood vessels, and it helps to nourish the bone that it sits on. So that periosteum is a buffer membrane in between the bony part of the ear canal and also the skin that lines the ear canal. So it kind of sits in between. And it helps to, as I said, nourish the bony part of the ear canal, provide it with a blood supply. Without that bone can die and become diseased and erode away. And so, when you're exposed to cold water or air, the blood vessels and capillaries in the periosteum dilate, and when it dilates, it encourages new bone growth and new bone development, and that's the clinical reason as to why people develop exostosis, surface ear. Ear canal osteoma is not, as I said previously, it's not always caused by cold air or cold water, and the exact cause, as I mentioned, is not really fully understood as yet. It could be due to some trauma to the ear canal or some other factors. Osteomas are normally singular, they're solitary. In my experience again, and it's only anecdotal, they're typically only in one ear, whereas exostosis is bilateral on both sides. And this doesn't need any treatment. You'll see it in a moment. So this piece of wax and skin is sitting on top of the ear canal osteoma, and I'm going to just take this away and it will reveal itself. The only time they need to be surgically treated in the ear canal is if they really do grow and they start to obstruct the sound passage. So it narrows the ear canal. You get stenosis. Sorry, I just had to pause the recording there. Just had someone at the clinic door just doing delivery. So yeah, they normally, we just leave them in the ear. There's no need for them to be excised or removed. Very occasionally they can grow and start to obstruct the insertion of a hearing aid. I've only ever come across that once. So they're not really troublesome in the mainstay. What I do notice, however, is when patients do have an ear canal osteomas, they are more likely to have a wax build-up. And I suspect that's because the skin that lines the ear canal, as that dies and sheds, and you've probably heard me say this a million times if you watch my channel regularly, the skin in the ear canal, as it dies and sheds, it's evolved to naturally work itself out of the ear, so it migrates itself, almost like a conveyor belt. And when you have an osteoma or exostosis, the skin, I suspect, it's more difficult for it to migrate because it's having to go over this bump that's caused by the ear canal osteoma, and it can lead to therefore wax buildup because the motion of the skin migrating also helps to expel earwax. So not only does the skin itself try to exit the ear, but it takes with it any earwax sitting on its surface. So for that reason, that skin migration is so critical within the ear. If it didn't occur, then all of our ears would be full of dead skin and no doubt full of earwax, because the earwax won't be able to, on its own, come out of the ear. So it's a very important mechanism our ears have developed over and evolved over millennia. So just some dead skin just at the roof of the ear canal, just using a fine end to mop up the skin. We're on the cartilage portion, so we kind of buy a bit of pressure here. The cartilage portion, unlike the bony part, it's not rigid, it's flexible. The skin that lines the cartilage portion is a lot thicker as well, so it provides a buffer. In fact, it's about 10 times thicker than the skin that lines the bony part of the ear canal, so just a bit more skin here. Now we're on the bony part, and you can see when I remove that skin, you can see the fresh layer of skin that's lining the ear canal. You can see that osteoma. I'm not sure how many years that's been there, but I've known the patient a few years and it hasn't really grown whilst the patient's been visiting myself. Now, this patient is moving to a different part of the country, so we've recommended someone more locally to them who's trained via our ClearWax ear care training course, so they come highly recommended for that reason. And what I've done for the patient and the specialist, I've actually airdropped this procedure to the patient to show their new specialist, because the specialist may not be aware of this osteoma or the locations. Even if we tell the specialist that the client's got an osteoma, they won't be aware of this exact location, and it just helps them perform the procedure. They're going to be careful in that region because it's a bony protrusion, and if you're not aware of it, you might dig in with it with the sucker or any other instrument that you're using. Well, I hope you enjoyed that video, guys, and you found it informative. Take care, speak soon, bye.